Intravenous therapy. Intravenous therapy is the infusion of fluids, medications, and blood products directly into the bloodstream or another anatomical space that has easy absorption into the bloodstream. The purpose of IV therapy is to restore and maintain fluids and/or electrolytes, provide a route for medication administration, allow for transfusion of blood and blood components, and provide a route for parenteral nutrition. We can also do blood sampling through several IV devices, and they can be drawn to, for example, for different lab tests. We can also draw them to determine therapeutic drug levels. For example, a gentamicin level that helps us determine the appropriate dosage of the drug. And if we're going to do a therapeutic drug level, we've got peak levels and trough levels. Peak levels would be done after a dose is completed, and the interval between completing and obtaining that blood specimen would be dependent on the specific drug. Now, if we're drawing a trough level, we draw that before we administer a new dose of medication, usually about 30 minutes before. Risks of IV therapy include bleeding, air emboli, blood vessel damage, fluid overload, overdose because of rapid medication absorption, allergic responses or adverse effects, incompatibility to drugs and solutions, along with the usual complications such as infiltration, extravasation, phlebitis, thrombophlebitis, nerve injury, and infection. IV therapy can be continuous or intermittent. We call those intermittent infusion devices saline locks, and we use those when a continuous infusion isn't necessary, but we still require venous access. We flush them with normal saline following the completion of an infusion, administration of medication, after we draw blood, and at the facility's required flush frequency, for example, every 12 hours. There's different types of infusion and delivery methods. We can go through the peripheral veins, the central veins. We can do an intraosseous, which is referred to as an IO, and that's used for rapid access in emergent life-threatening situations if we're unable to obtain peripheral vein access. Subcutaneous infusion is used for continuous infusion of isotonic fluids to treat dehydration. Intraspinal infusion is into the epidural space, the intrathecal or intraventricular spaces. It may also include intraarterial, intraperitoneal, and intrapleural. Delivery methods, again, include that continuous or intermittent. And with intermittent, usually we infuse over 30 to 120 minutes with volumes of 50 to 250 mLs. And we piggyback it into a continuous infusion line or infuse it directly into the infusion device. We can also administer medications through a push injection where we inject it directly into a continuous infusion line or inject it directly into an intermittent infusion device. And IV bolus is where fluid is infused rapidly over a short period of time. We also refer to IV bolus, although it's not the exact definition, as being a bolus of a drug that is given rapidly. The infusion system will include the solution container, the administration set, add-on devices, and a flow control device. The solution container is a flexible plastic bag, a semi-rigid plastic bottle, a glass bottle, or a syringe. Glass bottles or the semi-rigid plastic bottles are going to require venting to allow air to enter the bottle and displace the fluid. Syringes would be the containers of choice for pediatrics, and we use those with syringe pumps. The administration set is the tubing that attaches the solution container and connects to the IV access device. It is available in different lengths and diameters. We have a macro drop, which is 10, 15, or 20 drops per ml. In other words, it allows, for example, 10 drops to come through the drip chamber, and those 10 drops would equal 1 ml. We have a micro drop, which is 60 drops per ml, and that is the tubing that's usually used in pediatric therapy. If we use an administration set with an electronic infusion pump, it may require specific tubing that is specific to that particular pump. The tubing may also have a vent between the spike and the drip chamber, and once again, that's for use in those rigid or glass containers. The connections will have a lure lock to help prevent accidental disconnection. The spike and the male lure end that connects to the IV access device have to remain sterile. And we need to remember that frequent manipulation or disconnections increase the risk of contamination and infection. Add-on devices can include extension sets, filters, stopcocks, etc. Those extension sets are used for extra length, and usually they're going to remain on the IV access device. Stopcocks would be used for connecting multiple infusions to a catheter, and it directs flow of one solution to the IV access device while shutting off flow of other solutions. We frequently see that in OR, critical care, or trauma settings. Inline filters may be built into the administration set or added to the administration set. Filters are required with the infusion of blood products, parenteral infusions, and IV fat emulsions. It is necessary when you do have that filter to prime it to make sure that you remove the air prior to use. We do use filters in all pediatric therapy. We also need to refer to the pharmacy, fluid or medication inserts, or drug books to determine the need for a filter with certain medications. Needleless connectors are other add-on devices that can be attached to an IV vascular device, and they're built into most administration sets to minimize the use of needles. It's one of those safety features. They require strict disinfection measures prior to the use to decrease the risk of contamination. We can use the chlorhexidine, which is by far the preferred disinfectant, or we can use 70% isopropyl alcohol or povidone iodine. And we need to do vigorous scrubbing for 5 to 60 seconds. A plastic cap containing alcohol can be applied to the connectors. They don't require the scrubbing initially, but it does require scrubbing between different medications and flushes. Flow control devices can be manual, mechanical, or electronic. The manual includes slide clamps, roller clamps, and flow regulators. Mechanical may be one of those elastomeric balloons, spring-based, or negative pressure pumps. Electronic would include the infusion pumps and syringe pumps. They help regulate the rate and volume of infusions, which improves the safety and accuracy of fluid and medication administration. They can be programmed with volume and rate for continuous infusions and piggyback medications. And some infusion pumps can deliver more than one continuous infusion or piggyback at a time. Electronic pumps have alarms for air in the line, occlusion, completion of an infusion, and a low battery. There may be other alarms on some machines. It is important to be familiar with the function of the pumps that the facility you are employed at uses. And most important to remember, this does not negate the need to monitor the client's IV site and the infusion rate. Factors that will affect flow rates will include the height of the solution container from the IV access device, the amount of fluid in the container, the thickness or viscosity of the fluid, and client movement or position. We can also apply a time tape to help the nurse know at a glance if an infusion rate is accurate. If a solution is administered using a roller clamp to regulate the flow, we measure that in drips per minute. If a solution is administered through an electronic infusion pump, we measure that in mLs per hour. The nurse should monitor the IV infusion site and infusion every time the nurse is in contact with that client. With non-irritating and non-vesicant solutions, we should be monitoring every 4 hours. With critically ill clients that are receiving sedatives, clients that have cognitive deficits, or IV sites that are in a joint flexion area, we should be monitoring every 1 to 2 hours. With infants and pediatrics, we need to be monitoring at least every hour. And if we need to infuse a vesicant solution into a peripheral site, which is not recommended to begin with, but sometimes there's just no other way, we need to monitor that site every 5 to 10 minutes. We should, with vesicant solutions, encourage the central vascular access device. Monitoring of an IV site would include inspection of the entire system. We start at the bag and work our way down to the client, or start at the client and work our way up to the bag. So we need to look at the solution and the label, the tubing and the label, the connections, the site, the dressing and the label, the flow control devices, etc. There's several different types of catheters. We know that we usually have peripheral or central infusions. So therapies that are not appropriate for those short peripheral catheters include the continuous vesicant therapy, chemotherapy, parenteral nutrition, also known as TPN, and solutions that have a pH less than 5 or greater than 9, or solutions that have an osmolality greater than 600. So the first type of catheter we look at is the over-the-needle, and this is the most commonly used needle, and it's good for most short-term IV therapies. It consists of a plastic catheter slightly shorter than the stylet, which is the actual needle, a flashback chamber, and it may have a push button to retract the needle. The stylet is removed after successful completion, so all that remains in the vein is that plastic catheter. Winged infusion needles are also known as butterfly needles. They consist of a steel needle and flexible wings that fold, and they're held while we insert the needle. They're used for drawing blood or a single dose infusion due to high rates of complications if that needle is left in place. Midline catheters include peripheral IV devices that are used in the upper arm, and they're over 3 inches in length, up to about 8 inches. They do require demonstration of competency to insert. We use these when 1 to 4 weeks of IV therapy is required, but we should not infuse vesicants, TPN, or hypertonic solutions in these catheters. The intraosseous access device is used in emergent situations when a peripheral catheter might be impossible. It can be used for all medications and fluids. However, it is a short-term therapy because of the increased risk of infection, and it can only remain in place for up to 24 hours. Insertion is accomplished with a small drill, or they do have manual needles, and competency must be demonstrated prior to using this device. Preferred sites for the IO are the distal proximal tibia, the proximal humerus, and the sternum. They are contraindicated in clients that have bone disease such as osteoporosis, fractures above or below the intended site, infections or burns near the site, and a history of orthopedic surgery with hardware at the site. Lidocaine is often used for insertion, and we also use lidocaine during the insertion for the simple fact that we have a limited space to infuse this fluid, and sometimes it can be painful. The most common complication for interosseous is infiltration and extravasation in compartment syndrome. Subcutaneous infusions and access devices are something different. They don't necessarily go into the vein. They're used in clients that have limited vascular access, such as clients that are in hospice or palliative care, and they have mild or moderate dehydration. They may be in need of continuous opioid administration or immune globulin. It does require adequate subcutaneous tissue. When these sub-Q infusions are used for hydration, the site must be changed every 1.5 to 2 liters of solution infused. And if it's used just for medication administration, we would change the site every 7 days. It does require competency demonstration prior to being able to use it. The volume to infuse would be similar to the IV routes. It usually does require an infusion pump. The administration set itself has a needle, a short needle at a right angle to an adhesive platform, or can use a 24 gauge short peripheral catheter inserted at a 45 to 60 degree angle. Make sure that you aspirate for blood return prior to use, because we want to make sure that we have not inserted this into a vein. The sites would be the back of the arm, the upper chest, below the clavicle, the anterior or lateral thighs, and the abdomen at least 2 inches away from the umbilicus. And of course, make sure that you avoid joint areas or areas of skin impairment. Prior to insertion of a sub-Q device, you need to cleanse the site with a chlorhexidine preferably, or alcohol, and of course allow it to dry. It's necessary to assess those sites frequently. And if it's we move on to the central venous access devices. These allow for greater dilution of fluids and medications due to larger blood vessels. So in other words, if we have a trauma victim or a victim that is bleeding out the central line, we can infuse massive amounts of fluids, or we can infuse medications that are very irritating to the vein, etc. We can also obtain the blood samples in clients that have those poor peripheral veins from the central lines. There is reduced vein irritation from the vesicants. The central access devices usually have multiple ports for medication or fluid administration. And when you're looking at those multiple ports, they will be labeled. For example, there's 3 ports. You would have medial, proximal, and distal. And if you look at a catheter, the proximal is going to be the one that is closest to the device, or there will be a hole that is designated on the tubing, and they're approximately an inch apart or half an inch apart. This allows for multiple medications to be administered through the same device because the amount of blood is going to help dilute the medication, less chance of compatibility issues with the medications. It does require more skill and time and resources to insert, so this is usually done by a physician. So we need to consider inserting a central device when we have the solutions that have that osmolality greater than 900, the chemotherapeutic agents that we're going to be infusing for longer than 3 months, parenteral nutrition, inotropic agents, high concentrations of potassium chloride, long-term intermittent infusion therapy, if we need to do pulmonary artery monitoring, or we have failed or difficult peripheral access. So we have some of the same risks with central devices that we do with peripheral venous access devices, but then we have some different ones. If you consider where some of those central lines are, consider the organs that are adjacent to or near the insertion site. For example, the lungs. So a complication would be accidentally puncturing the lung during the insertion. So we have a pneumothorax. So it is a standard to obtain a chest x-ray following insertion and monitor for any other potential damage to adjacent organs. There's also an increased risk of air embolism, and it's important to always clamp that catheter before the catheter hub is open to air. There are several different types of central access devices. We have the peripherally inserted central catheter, or the PICC. Now this one's a little confusing because it's in the arm versus being in the upper chest or neck. So it goes through the peripheral vein in the upper arm, and then the long catheter is then advanced to the superior vena cava. It's most appropriate in clients that require more than 6 days of therapy, and it's often preferred for these clients that go home and require extended IV therapy because of the ease of access and for the cosmetic appearance. Then we have non-tunneled catheters that go through the subclavian or internal jugular vein, and they're advanced to the vena cava. They're usually indicated in clients that require short-term vesicant therapy or hemodynamic monitoring, such as a central venous pressure. Tunneled cuff catheters are going to be for use in clients that require therapy for 1 to 3 months, such as cancer. Subcutaneous tissue will grow into that cuff to assist anchoring it and also help prevent infection. And then we have the implanted ports, and that's for use in clients with long-term chronic diseases that require long-term but intermittent therapy. That port is implanted in subcutaneous tissue under the clavicle, and then it's advanced to the superior vena cava. It has to be accessed with a special non-coring needle called a Huber needle, and that's Huber. So it's very important to prevent infection. We're going directly into the bloodstream, so any contaminants can easily cause an infection. So hand hygiene before and after all infusion procedures. Using that single-use tourniquet. Wearing gloves for catheter insertion. Now, clean gloves for insertion. Sterile if you're doing a sterile procedure such as the central catheter. Thoroughly scrub that insertion site with an appropriate skin antiseptic and allow it to dry completely. Touch the cleansed skin only with sterile gloves. Ensure that the catheter hub is adequately secured. Ensure the dressing is intact. Use a new catheter for each insertion attempt. And do not contaminate the sterile ends of the catheter or administration set. Complications of IV therapy can be local or systemic, and they can even be life-threatening or life-altering. It's important to use appropriate techniques, frequent assessment to identify potential complications, and implement appropriate interventions when things are not looking right. Prevention of those complications is going to be extremely important. So local complications can include infiltration, extravasation, phlebitis, thrombophlebitis, cellulitis, infection, occlusion, and nerve injury. Systemic complications can include air embolism, bloodstream infections, speed shock, circulatory overload, allergic reactions, and adverse reactions to different medications. So, infiltration and extravasation. Infiltration is the unintended infusion of non-vesicant fluid and medication into the surrounding tissues, while extravasation is the unintended infusion of a vesicant fluid or medication into the surrounding tissues. Now, a vesicant is defined as any fluid or medication that can cause tissue damage or necrosis, and it can lead to necrotic ulcers, compartment syndrome, complex regional pain syndrome. We may see with either of these swelling at or around the IV site, pain, a feeling of tightness. The skin may feel cool or warm, blanching or redness, absence of a blood return, or an altered flow rate. To treat it, remove the device. Make sure that you aspirate the contents prior to removal. If it is an extravasation, we want to pull all of that medication out so it doesn't continue to cause damage or damage in a new area. Elevate the arm, cool or warm compresses. Administer an antidote with extravasation if there is one available. Phlebitis is inflammation of the vein wall, while thrombophlebitis is the inflammation of the vein wall with a clot in the vein. We might see pain, redness, edema. The vein might feel hard or cord-like. It's necessary to remove the device, apply heat, analgesics, and anti-inflammatories. With infection, we may see redness along the vein or in the area. Cellulitis, we may also see swelling, hardness of the vein, purulent drainage, and an increased body temperature. Again, remove that device. We may need to culture the catheter or the exudate if it's prescribed and administer antibiotics. With an occlusion, we have a change in the flow rate. The electronic infusion pump may alarm, and the client may experience discomfort. It's important to inspect the system for kinks or closed clamps because that's often the most common problem. Flush that catheter, but don't force the flush. If resistance is felt, stop the flush immediately. Use a warm compress if a venous spasm is the cause, and remove the device if necessary. A hematoma is tenderness and swelling at the site along with bruising. Remove that device, apply pressure and cool compresses, elevate the arm, and reassess. Nerve injury would be extreme pain like an electrical shock, shooting pain up or down the arm, paresthesias, paralysis, and deformity. If a client complains of these things, stop insertion and remove the device. Don't continue to make attempts to access that vein. So with systemic complications, we have the bloodstream infection. The client will have a fever over 101, chills, malaise, nausea, vomiting, abdominal pain, shortness of breath or confusion. Administer medications as prescribed, obtain cultures of the catheter or exudate, and monitor vital signs. A vasovagal reaction would consist of lightheadedness or dizziness, pale skin, hot and flushed or cold and clammy skin, nausea, blurred vision, a slow, weak pulse and decreasing blood pressure. Assess for fainting and monitor the client's vital signs. With circulatory overload or pulmonary edema, the client may have pain, neck vein distension, respiratory distress, increased blood pressure and heart rate, crackles in the lungs, edema, weight gain, restlessness, or a cough. Elevate the head of the bed, administer oxygen, and we may need to slow the rate of the IV. Speech shock would be a sudden physiological reaction when IV drugs are given too fast. These clients may experience a headache or dizziness, facial flushing, chest tightness, hypotension, and an irregular heart rate. Stop that infusion and call rapid response. If an IV cannula, or the next complication is an air embolism. An embolism can be a blood clot, air, a piece of the IV catheter, etc. And once again, if an IV cannula flushes with difficulty, don't force it. You should never try and flush away that resistance because you might be dislodging a clot. It's always recommended to aspirate if you have resistance. So with an air embolism, we need to realize that 10 mLs of air can cause an embolus. So it's important to monitor your IV lines closely. If an air embolism does occur, discontinue that infusion. Administer 100% oxygen. Turn the client to the left side with the head lowered to encourage absorption of air into the right atrium. Notify the physician and keep that emergency cart close. These clients are at extreme risk of life-threatening issues. The client will experience shortness of air, hypotension, chest pain, and potentially shock or cardiac arrest. We may also see lightheadedness, respiratory distress. So clients with an air embolism may experience shortness of air, hypotension, chest pain, and potentially shock or cardiac arrest. We may also see lightheadedness, respiratory distress, unequal breath sounds, a weak pulse, confusion, disorientation, and loss of consciousness. With an allergic reaction, we may see itching, watering eyes and runny nose, bronchospasm, wheezing, rash, and anaphylactic reaction. Stop that infusion immediately and infuse normal saline. Maintain the client's airway, administer medications, epinephrine, steroids, anti-inflammatories, and antipyretics. So, pediatric considerations. Use vascular visualization tools. Consider the client's age and their activity level. For example, if they're a thumb sucker, we don't want to be putting an IV in the client's hand. And consider the reason for the IV therapy when selecting that site. Scalp veins should not be used in clients that are older than 6 months of age. And remember, LPNs cannot access these veins. Feet may be used in infants or children that have not begun to walk. In neonates, we may insert an umbilical catheter, but that's usually done by the physician. Do not allow the client to see the equipment if possible. So always prepare things outside the room. It increases their anxiety if they start seeing needles. With insertion, consider pain relief. Topical is definitely a good method. We can also do injectable. And in the infants or neonates, we can do a oral glucose in their mouth or on a pacifier. Use age-appropriate distractions. Explain the procedure using age-appropriate wording. Use a 22 to 24 gauge catheter in infants and young children. Always use an assistant to help prevent movement during an insertion. Never try to do this by yourself. An assistant can also provide a tourniquet effect if necessary. If resistance is felt during the threading of the catheter, allow the child to relax before trying again. After the procedure, praise the behavior regardless of how cooperative the child was, and allow the child to talk about or play out their feelings. We always use commercial stabilization devices if possible to help protect the site. To protect the skin, we may need to place gauze underneath the hub. If applicable, if the child is old enough, advise them not to play with the site and equipment. Use stretch netting to help keep things in place. Use an arm board or hand board if necessary. Monitor that site frequently, at least hourly. Fluid administration should not be done by gravity in the pediatric client. Usually use an infusion pump or a syringe pump. Use a microdrip set or a volume control device such as burette tubing. A burette device has a large chamber that inserts into the solution container. You fill the chamber with enough fluid to infuse over an hour's time and then clamp the solution container so no additional fluid can be infused during that 1 hour time. With older adults, use the least amount of adhesive possible because of their fragile skin, and remember their veins are more fragile. Always avoid flexion areas, areas with bruising. Try to avoid the dominant extremity if possible. Do not use those small spider web veins. Don't use the hard sclerosed veins either. Always use the smallest gauge and shortest length possible. Monitor for fluid overload. Palpate those veins gently. A tourniquet might not be necessary, but if you do use one, try not to tighten it too much. Stabilize that vein wall well. With the older adult, the direct method of venipuncture is often the most appropriate. We may also do subcutaneous infusions in the older adult. Site protective measures, we need to realize that with our agitated, confused, or restless older clients, sometimes these are necessary, and that may include a long-sleeved gown, hand mittens, flexible elastic netting over the site, the arm board, and again, always use those commercially available IV site protection devices if possible. Nursing priorities have the most impact on the client receiving the IV therapy. Potential for injury would include trauma, infiltration, and extravasation. And there's also potential for infection from cannula irritation, medication irritation, and non-adherence to aseptic technique. And then we have fluid volume excess in clients that have impaired renal or cardiac functions, or any infusion in which the client does not receive appropriate monitoring. And then we have impaired peripheral circulation from emboli or thrombi.